care from the healthcare system. 7 of whom actually spent some time in a hospital ward, and that's everything from just overnight to several months. 5 people, so more than a quarter, report that they did not seek out and they did not receive any help from the healthcare system. And this included one subject who reported that they had actually made a suicide attempt. And in 2 cases, I was told, as the interviewer, that I was the first person they'd ever told about their suicidal thoughts. Here's what one person said who did not seek care. I think the reason I didn't want help was because I thought of it as a formal, intimidating thing. Not even on a couch, sitting in a chair that's uncomfortable, just so uncomfortable. Like Mambo. So here are some things, so beyond the simple stats that I just gave you, there's some themes that we're seeing emerging. I'm not going to speculate yet, as I mentioned, but let's go over these one by one. So the first theme is treatment needs, and I'll focus on met needs. There's unmet and met needs, and we'll focus on met needs first. So we asked people what help they have sought and what it was like for them. Often their perceptions of the treatment are complex. Sometimes a bad experience in the emergency room or hospital or with an incompetent therapist can be horrific at the time, but can make sense later on, or be part of a trajectory that leads to competent and effective care. Sometimes, however, their engagement with the healthcare system clearly reveals an unmet need. So let me give you a couple of examples of met needs. One participant told me they were brought under police supervision to psych for suicide watch. They realize now that that unpleasant experience led to empathetic and effective care due to responsible follow-up by a ward doctor and a social worker. In their case, even though it was certainly a very difficult time in their life, their hospital experience would be considered a met need. Another example of a met need is a sustainable, ongoing connection with an effective therapist. By sustainable, I mean the funding is in place, there's no time constraints on the length of time they're able to go. And they've built a good trusting relationship, therapeutic relationship with that doctor or counselor. So many of our subjects have actually been able to find ongoing support from a psychiatrist, a psychologist, a counselor, group therapy, support groups, etc. So just going down the list, I've talked about the first 3 points. There's also UBC counseling services, which kicks in for UBC students as interim therapy until the crisis is over or until they're connected with more ongoing care. UBC Health Services, that's therapy that's offered through psychology building at UBC. Crisis line, this is what you were referring to earlier. We do have a 24-hour call-in crisis line. Some people who did find it effective cited the fact that it's immediate and it's anonymous, so they were able to be honest. Emergency response, that includes anything that you get when you call 911, police, ambulance. Again, it's life-saving, so that's a net need. I mentioned social workers, the person I mentioned above. And I should also say that almost everybody who accessed effective ongoing care went through their GP first. So on the unmet needs side, another participant who I talked to was turned away from the ER with no support, no referral, no discharge plan, no follow-up, because we're not deemed to be acutely suicidal enough. And this case reveals to me an unmet need. Inappropriate referral is another unmet need that we're looking out for. For example, in contrast to the example in the last slide, in a rural northern region, no psychiatrist existed to follow up with the subject after a suicide attempt. So the subject was referred to a social worker who had no training to work with suicide. He was actually more equipped to take away children from their parents than to actually facilitate help. So here's a list of the unmet needs, and there's some overlap because obviously not everything's going to work for person. So the ER, turned away the ER, inappropriate referrals. Mental health teams, a lot of people mentioned trying to access mental health teams, but the wait lists reported and several months long. The person told me that it would be an 18-month wait to get hooked up with a mental health team. Time-limited therapy, that's the UBC counseling services that I was discussing. It wasn't quite long enough. There was no care that was in place after the end of the brief intervention. Discontinuity of care. This is when care is interrupted or discontinued when the patient moves cities, or when the patient becomes an adult and moves from the youth to the adult system. Ineffective therapy. This one's kind of tricky because it's more subjective, but that's where boundaries haven't really been set. Trust isn't built. They don't feel like it's a good therapeutic relationship. Psychologists, they're very expensive, and so often that is a met need. Psychiatrists, the wait list was often reported as being way too long. And some participants who did have psychiatrists reported finding it hard to build a relationship within a 10-minute appointment time frame. That's shockingly typical. Is there a train? The crisis line worked for some people, but it didn't work for everybody. Some people felt no connection with a total stranger on the opposite end of the phone. And they also said, one person told me it's a bit of a crapshoot. You don't know who's going to pick up the phone. It could be somebody with a lot of skill, or it could be somebody who's completely inept. So they didn't feel comfortable doing that. So I realize I might make some enemies by saying this, but at least Dr. Hill's not here to hear me. But because the first item on the list, oh, he is, oh dear. Forgive me in advance. Because I'm about to talk about emergency room. I feel like it's important to address this, and this is probably going to be no shock to you. I went to the Mood Disorders website and looked a little bit at what they said about emergency room access. So consumers and families typically report that wait times in the ER are excessive. Anecdotally, the common experience of wait times is at least 5 hours, but often 10 hours or even longer. And this doesn't really jive with what the Canadian Institute of Health reports. They say across the country, the median wait time is 2 hours, with only 10% of patients spending 6 hours or more, depending on the severity of their illness, the age of the patient, the time of day, etc. So to make sense out of this, of course, there's a priority rating scale, which there has to be in an emergency room. And in the lowest priority bracket, non-urgent conditions such as sore throat, conditions that can be referred to other areas of the healthcare system, or psychiatric complaints that do not involve suicidal ideations or threats. And that kind of explains that really being turned away. Okay, the second theme here is perceptions of treatment. So it's beneficial and damaging outcomes. So beneficial outcome would be one that encouraged help-seeking, continuation of care, stabilization in many aspects of life, community and skills building, empowerment, improved health, etc. And an example is revealed in the following story. A social worker on a psych ward hooked up a patient with Access to Diversity, which is an agency on the UC campus that assists people who are mentally ill or with mental health issues, so that this person's academic career would not be impacted by their stay in hospital and beyond. The subject reported that not only did Access to Diversity negotiate with the university to stay their impending expulsion for academic low marks, but they also arranged funding for on-campus housing for the following term to reduce the stress caused by a 4-hour daily commute for this person. So this positive interaction with the healthcare system also resulted in that subject continuing on in therapy. On the opposite side is damaging outcomes. So a damaging outcome would be the opposite. Something that ended or impeded health-seeking behavior, stabilization, community, health, etc. So an example that I was told more than once was pill pushing. A psychiatrist who pressures patients to try medication. This seems especially damaging if the doctor spends little time in assessing or talking with the patients before prescribing. So we've already talked a little bit about the barriers to care, so I'll try not to go into long here. So I kind of think of it as external barriers and internal barriers. This is interpersonal barriers is the first thing I want to address here. So these include fear of stigma, fear of a negative experience or judgment by healthcare providers, minimization or validation of their symptoms, or sometimes the opposite, fear of validation of their illness, like if I seek help, then I must be really bad. Also feeling of not wanting to be burdened, that was that self-reliance thing we were referring to earlier. So the power of such fears is very real, and has a very real impact on whether or not a patient seeks care. And sadly, the stigma is also very real. There was a study done in Alberta in 2007. The researchers found that 43% of Albertans believe depression is caused by a weakness of character.